Welcome to this screencast on neonatal cholestasis, focusing primarily on the management principles. This screencast is meant to accompany a prior one that was focused on the pathophysiology of cholestasis with a emphasis on the neonate and why what features of the neonate make them more susceptible to the development of cholestasis or manifestation of cholestasis as an early sign of liver injury. The objectives of this screencast are to first discuss why the diagnostic evaluation, which I'm not going to go into in great detail, why it's so important to be able to identify some of the underlying conditions presenting with neonatal cholestasis, as there are a certain number of disorders that are amenable to specific medical therapy, which can potentially be curative and reverse the liver injury. And in other circumstances, in the case of anatomic abnormalities, can be responsive to early surgical correction, again with potential cure. And the main focus of the talk is going to be to discuss the three major pathophysiologic consequences of chronic cholestasis in the infant, and hopefully apply these principles to help understand what management options are out there, as well as potentially some preventative, usually secondary preventative options for prevention of progression of disease. Unfortunately, a lot of these options are general supportive measures and are used in all cases of neonatal cholestasis that are quite significant, and in particular ones where reversal of disease is unlikely. So as promised, I'm not going to be going into great detail about diagnostic evaluation. First, to recap, cholestasis refers to a reduction in bile flow, either due to impaired secretion by the hepatocytes or cholangiocytes within the liver, or due to obstruction of the bile ducts either within the liver known as the intrahepatic bile ducts or outside of the liver known as the extrahepatic bile ducts from their point of the porta hepatis to where they enter, where the colon bile duct, the pancreatic duct, and enters into the small intestine. And when we think about the pathophysiology in those two main groups, if you think about the hepatocellular causes, there are a select number of them for which early and prompt diagnosis can lead to effective therapy that is specific to the underlying condition and will result in many cases in reversal of liver injury and cholestasis. And these are broadly grouped into a few major categories. The first would be infectious, and of the infectious processes, most are congenital infections, for which there is a specific treatment available. And an example of this would be herpes simplex virus, which actually can present systemically in the neonate and be transmitted perinatally. And another example of congenital infection for which there is a potential treatment would be toxoplasmosis. Other examples include syphilis, HIV, tuberculosis. Of the metabolic endocrine group, there's a large number of underlying diseases for which treatment will not only prevent cholestasis and treat this, but will also prevent significant morbidity and mortality from other manifestations of the disease. And an example of this would be galactosemia, which is a problem with the ability to handle galactose, which is a major component of lactose, which is found in breast milk and many formulas. So going on a galactose-free diet can be curative and would be important to diagnose early before the development of progressive liver disease, as well as other things such as E. coli sepsis, cataracts, etc. Another example of this would be hereditary tyrosinemia and hypothyroidism and hypopituitarism, the latter of which respond to specific hormonal replacement. The third group, which is probably less numerous but still significant for gastrologists and hepatologists to be aware of, would be the bile acid synthesis defects. They are being increasingly recognized with better testing and result in an enzymatic deficiency in one of the enzymes within the pathway that produces bile acids. And if you can't make bile acids, as we talked about, they are a major driving force for bile flow. So correction of this disorder would be with supplementation of the appropriate bile acids. Drugs and toxins would be the last group. And intuitively, if you find an underlying iatrogenic cause or a toxin from sepsis, from a bacteria or other etiology, then the appropriate response obviously would be to try and find an alternative or limit the use of that medication. Or in the case of parenteral nutrition, limit the use of parenteral nutrition as best as possible. A congenital anomaly of the bile ducts with cystic dilatation, for which the treatment would be surgical excision of the cysts, the cystic mucosa with, again, a reconnection of the area proximal to these cystic dilatations and the small bowel. If caught early, then prevention of further liver injury can result. And finally, as we mentioned, a lot of these underlying disorders, even if there aren't specific to, don't have a specific therapy associated with them, they can be associated with extrahepatic manifestations for which treatment can be provided, or increased surveillance can be done to prevent morbidity and mortality from these underlying issues. But remember, there are many cases, again, probably over 90% of infants with cholestasis where a specific etiology presenting options for specific medical therapy or surgical therapy is not achievable. And so in this case, the focus shifts to supportive management. And while supportive management may conjure images of inability to help, in fact, there is a lot of good that can be done regardless of the inability to actually cure the process. So goals of care in pediatrics go in a few different directions. One is to optimize the growth and nutrition, and this is really important because if the patient does end up progressing to end-stage liver disease, ensuring this prior to transplant will optimize their best chance of success later on. Minimizing discomfort and disability associated with the manifestations of cholestasis, the physiological consequence of cholestasis, which we'll talk about. And thirdly, the main goal would be to help patients and families cope with some of the psychological and social effects of having to deal with a chronic liver disease. And the best way to do this is to meet all of these goals is to think about what consequences can occur with chronic cholestasis, regardless of the underlying process, and then provide options to help prevent progression and to also treat, if possible, to prevent further consequences. So now I'm going to talk about the three major pathophysiological consequences of cholestasis and potentially offer some options that follow from this knowledge to be able to treat. So the first thing that we think about is that the constituents of the bile which as mentioned in the previous screencast include things such as bile acids, bilirubin, cholesterol, and trace elements. All of these constituents, which are not excreted within the bile because of cholestasis, are all retained within the liver, and this hepatic retention can cause problems directly to the liver itself. And we think that the most hepatotoxic constituent of the bile is bile acids, and specifically the hydrophobic bile acids, which are water hating, as the name implies, or fat soluble. And these bile acids actually make up the vast majority of the bile acid pool in humans. And why they are so toxic is becoming better elucidated. For one, the hydrophobic bile acids act as detergents, and in that way they can alter the membrane composition and function of the liver cells. They also can inhibit the enzymes within the liver and interfere with mitochondrial permeability. Secondly, they are signaling molecules in and of themselves, and they can stimulate cell death receptors and activate signaling pathways for apoptosis and cell necrosis. And as you would expect, this is a progressive, can result in progressive liver injury. So initially it can actually result in portal fibrosis or scarring around the portal tract from the cell death, and can actually lead to further impairment in hepatocellular function, which includes cholestasis, and thus a perpetuating cycle can develop with worsening cholestasis as a result of the underlying process itself. This can further progress to portal hypertension, where the blood flow within the liver itself becomes poor and then it backs up due to increased resistance from the scarring within the portal tracts that include the blood vessels. And then eventually, over time, the degree of scarring can become so significant and extensive that liver generation is no longer possible, and you have a state of cirrhosis. In conjunction with this, you can get eventual hepatic synthetic dysfunction or liver failure. So treatment naturally for the retention of bile constituents within the liver comes in two forms, but the main one is to try and improve the bile flow and get that bile constituents out of the liver cells and the liver parenchyma. So this is where choleretics come into play. These are agents that improve bile flow, also known as choleresis, and ursodiol is the best studied and has the best evidence for it, and is generally safe medication to use. Ursodiol is actually a naturally occurring bile acid in humans, but it only comprises under 3% of the bile acid pool. However, it's increased to probably 40% of the serum bile acid concentrations when patients are on ursodiol. And it is thought to work in a number of ways, independent of its effect on choleresis. So first and foremost, it actually works as a choleric agent, increasing both bile salt independent flow and bile acid dependent flow. So it does have a hypercholeritic effect, but it also seems to be protective to the liver by displacing the toxic hydrophobic bile acids from the circulating pool, and they are thought to do this by interfering with their absorption in the small bowel. They also have been shown in vitro and in animal studies to protect the hepatocytes that are exposed to toxic hydrophobic bile acids, possibly because they stabilize the cell membrane or improve mitochondrial oxidative phosphorylation and prevent the mitochondrial membrane permeability transition, which is thought to be an important step in apoptosis and cell death signaling. Last, they actually are thought to now have an important immunomodulatory role and reduce the immunologic injury associated with some of the specific cholestatic diseases for which there is an immune mechanism for injury. And there is some evidence clinically in several diseases associated with cholestasis for which there is no specific medical therapy, and examples of this would include in cystic fibrosis and Alagille syndrome. as well as possibly for use in intestinal failure-associated liver disease. Now, other cholestics have been studied, and one that shows quite a bit of promise is toro ursodeoxycholic acid, which is a conjugate, it's a taurine conjugate of ursodiol. And the thought is that it may work better in enriching the hydrophilic component of the bile acid pool. But again, it has not been studied in pediatrics, to my knowledge, as of late. Phenobarbital and corticosteroids both have evidence for choleratic effects. However, their side effects generally preclude their long-term use in pediatrics or in patients in general. Now, last, for treatment of the hepatic retention of bile constituents is the concept of using an antifibrotic. Now, I mentioned that bile acids induce their effects from the direct toxicity and the promotion of cell necrosis and apoptosis, which eventually leads to scarring. So the thought is, if we can't necessarily improve the bile flow, can we prevent this progression of scarring through the use of antifibrotic agents? And again, these are not currently available for use, but are under investigation. So the second consequence of cholestasis is that now you not only do you have the buildup of these bile constituents within the liver itself, but these constituents then leak into the sinusoidal spaces and then thus into the systemic circulation, and increased amount in the blood can this lead to other problems elsewhere or extrahepatic consequences. Not only is this one thought as to why the levels can accumulate in the blood, but also potentially because the liver is trying to protect itself. It is when the enterohepatic circulation occurs and the bile acids are then recirculated after being absorbed in the small intestine to the blood, they need to be taken up again by the liver cells, and the liver is trying to protect itself actually by decreasing bile acid uptake from the blood in times of cholestasis. So it's another reason why these levels accumulate. And the results are primarily seen in these three ways. So first is pruritus or itching. Second would be fatigue and altered behavior, so CNS consequences or central nervous system. And third would be hyperlipemia and cutaneous xanthomas, which we'll talk about. So pruritus can be a very distressing manifestation of cholestasis, and it is not thought to be as severe in infants, although this can obviously not be proven. But we tend not to see a lot of scratching and excoriations in younger infants. Severity can be mild and not causing any significant interference, but it can also become very severe, tractable, leading to significant skin lesions that become infected or scarred, interference with sleep and concentration, and significant impairment in quality of life as a result. So this is a nice summary of our current state of knowledge about pruritus and cholestasis. So based on clinical observations and studies, we know that whatever is causing itch in cholestasis does tend to accumulate in the systemic circulation, because patients who have been given plasmapheresis or albumin dialysis actually have significant relief in their pruritus. We also know that it is secreted into the bile because nasobiliary drainage or cholestyramine, which we'll talk about as a bile acid binding agent, can relieve sensation of pruritus. We also know that it's whatever it is biotransformed or processed within the liver and or the gut because of clinical observations have been proven pruritus with a potent agonist of the PXR, which is a nuclear receptor which acts to upregulate enzyme activities, particularly CYP3A4, an oxidative enzyme that is responsible for the metabolism of drugs and other entities. And it also upregulates conjugating enzymes and bile acid transporters, as well as other bile transporters. And finally, we have had some evidence for some time that whatever the entity is within the blood that increases itch actually acts on specific neurons that are then transmit these messages to the central nervous system. And the transmission of the message can be altered by opioidergic and serotonin related input. What we now think is that this entity within the bile that can promote itching and again builds up in the blood is known as lysophosphatidic acid, or LPA. And to form LPA, you need enzymatic activity to convert lysophosphatidylcholine, and this enzyme has been identified as something known as autotaxin, which in and of itself does not get secreted into the bile, but levels do increase in cholestasis in the blood, and perhaps it is due to some undetermined factor that will upregulate its activity and can be secreted in the bile. So knowing all that allows for some opportunities for specific treatment in pruritus. One option, as I said, the pruritogen is secreted in the bile, so can we do something to promote bile flow? And that's where cholestyramine comes in, as they act to bind many agents within the intestinal lumen, including several constituents of the bile, and thus interrupt the enterohepatic circulation of bile acids in particular, but also through these mechanisms may stimulate choleresis in general or bile flow. I should also mention the ursodiol by inducing choleresis is the first-line management for choleresis due to its choleretic effect with minimal side effects. So it's the first line. Cholestyramine is usually the next line agent. Rifampicin, as we had talked about, increases activity of enzymes and transporters within the liver through its effects on nuclear receptors. And so it potentially offers a therapy. But another reason why rifampicin may be effective is that it can reduce autotaxin expression and has been shown to do so in vitro studies. Finally, due to the potential effects on the opioidergic and serotonergic systems, naltrexone, which is an opioid antagonist at the mu receptors, as well as the serotonin reuptake inhibitor sertraline. These have also been shown to have some efficacy, but are considered third and fourth line agents respectively on the most recent recommendations. The other results of accumulation of serum bile constituents are now going to be described. The first is altered behavior and fatigue. Now, both of these have been described, probably are more significant in adult patients with chronic cholestatic liver disease, however, have been described in pediatric populations as well, and are often out of proportion to the degree of liver disease and may occur prior to the development of severe chronic liver disease, which is often associated with these changes that could be explained better by hepatic encephalopathy. Now, in chronic cholestasis, the thought is that there's some altered central neurotransmission, and serotonin and actually opioid tone have also been implicated. However, again, this is not well understood what is contributing to this, so thus no specific treatment options are available other than the supportive measures already discussed, predominantly methods to induce choleresis. Now, hyperlipidemia and cutaneous xanthomas are better described as to how they occur, but again, there are some gaps. So the thought is that bile phospholipids leak into the plasma and induce secondary effects such as the increased synthesis of cholesterol by the liver, as well as altered metabolism of lipoproteins, which serve as the major transporters for fats and cholesterols to move around the circulation. So the consequences of this then are increased serum cholesterol levels, and as a result of the severely high levels of cholesterol that can develop over time, these these can lead to deposits of cholesterol and lipids in the skin or mucous membranes known as xanthomas, and also can deposit within the arteries themselves and lead to significant atherosclerosis or obstructive disease involving the blood vessels. So how do we approach treatment? Well, not surprisingly, ursodiol is another, also seems to work for this manifestation, perhaps in part because of its choleretic effect, and can result in significant reductions in the hypercholesterolemia in children. However, there are other mechanisms by which it's thought to help, and one is that it has been shown to directly stimulate LDL, or low-density lipoprotein uptake within the liver, and decrease activity of the rate-limiting enzyme in cholesterol synthesis in the liver. And finally, it's also thought to indirectly result in a reduction in cholesterol absorption from the intestine. The other therapy, which we talked about a bit with the treatment of pruritus, but it probably has significant evidence as well here, is cholestyramine, which is an example of an anion exchange resin. And to understand a bit better how this may work, we also have to remember that cholesterol is a precursor which is used in the synthesis of bile acids, and this medication works to bind bile acids and take them out of the circulation by promoting fecal excretion or preventing reabsorption within the small intestine, thusing the intrahepatic recirculation. And the thought there is that this reduces the circulating bile acid pool, thus reducing the negative feedback that bile acids exert on bile acid synthesis within the liver, i.e. getting bile acids out, so you need to make more bile acids, so you're shifting the balance to increase cholesterol conversion to bile acids, and thus you're reducing the cholesterol levels. It should be noted that with both these agents, for the most part, you can't get the cholesterol back to normal range even with their use. What is also interesting and a bit frustrating for treatment is that the hypercholesterolemia in this case does not respond well to low cholesterol and low saturated fat diets, or the use of cholesterol synthesis blocking medications which have good evidence for use in familial and other causes of hypercholesterolemia. So we've talked about two major pathophysiologic consequences of cholestasis thus far. The first, just to recap, would be the elevation in bile constituents within the liver, predominantly hydrophobic bile acids, which cause direct hepatotoxicity. And we've also talked about the elevation in serum of bile constituents, which are probably variable, and in the case of pruritus may be due to lysophosphatic acid and some indeterminate factor which increases autotaxin activity, which will produce lysophosphatic acid through enzymatic activity, and also elevation of biliary phospholipids that lead to altered cholesterol regulation and severe hypercholesterolemia. The third consequence, which is of major importance to pediatrics, is actually due to insufficient levels of bile constituents, and these are the bile acids making their way into the small intestine. And this is a problem because bile acids, as I had mentioned prior, have a detergent activity and are able to solubilize both dietary fats, long-chain triglycerides primarily, and fat-soluble vitamins into these droplets known as micelles, which are much easier to work on to be broken down by the hepatic lipase and colipase activity. So if you don't get enough bile acids into the intestine because they can't be secreted because you have cholestasis, you have insufficient micelle formation for adequate digestion. And this manifests primarily as diarrhea, which can be watery, or steatorrhea, which is a description of oily, bulky, or greasy stools due to the persistence of fat that has been excreted in high quantities, and also failure to thrive because fat is very calorically dense, and also because fat makes up a very large component of the diet of infants and young children. Also, it can manifest with fat-soluble vitamin deficiencies, and the clinical manifestations of each of these can be important, particularly vitamin D and its importance in bone turnover and maintaining healthy bones, as well as vitamin K, which is very important in ensuring good clotting factor activity, and thus vitamin K deficiency can present with life-threatening bleeds if undiagnosed and unrecognized. And all of these nutritional deficiencies, of course, are occurring just from the underlying cholestasis, and this does not even account for the other issues that can result from the underlying disease itself, which can increase energy requirements and malabsorption through other mechanisms. So how do we manage this? Well, first and foremost, as we talked about, good nutritional assessment is really important, first at baseline, and also taking into account the patient's underlying condition, what their energy requirements might be, whether there are other alterations in the patient's metabolism as a result of the underlying disease, or other factors, as well as what their current caloric intake is. So a really good baseline assessment involving a dietitian and the gastroenterology team is crucial. And then from there you have to assume some things. So first of all, just looking at cholestasis, what are some of the issues that we're going to see? So first is as I mentioned, the fat malabsorption can really affect your overall caloric absorption. So you need to find other ways to get high calorie intake, and sometimes it just means pushing the formula at a higher concentration and hoping that even though there's malabsorption, you're going to be getting adequate absorption just from pushing the calories to a high amount. And so this can be achieved by increasing the concentration of the formula by putting higher amounts of powder with your formula, or in the case of breast milk, supplementing it with additional formula to increase its caloric density. And the thought is that the goal should start at about 125% the recommended dietary intake or allowance based on an ideal body weight for that patient in pediatrics. If this strategy is ineffective, then you have to think about why they're not absorbing and see if you can bypass this in another way. So the first option here is to use medium chain triglycerides, that's MCT, and these are dietary lipids which actually do not require or are dependent on micelle formation for their absorption, and thus are an important strategy to get extra fat absorption in patients with cholestasis. Second option is to use glucose polymers such as polyglucose powder, which again should be adequately absorbed in the patient, regardless of how acids they're producing, because glucose is not dependent on bile acid for its digestion or absorption. And when these strategies don't work, which is unfortunately often the case, then you need to think about other ways to get more calories in, and this often warrants the use of a nasogastric and the use of overnight feeds to provide more calories while they're sleeping. And this is particularly particularly important when intake starts to suffer or is insufficient. So growth is going to be followed closely. The other thing is, as we alluded to, providing extra fat-soluble vitamin supplementation in above and beyond what you would be normally recommend the diet of an infant. And while you're doing this, you'll be doing serial measurements of the fat-soluble vitamin levels to allow you to adjust the doses as needed. And lastly, there are a variety of other micronutrients, both vitamins and trace elements, that are found to be reduced often in patients with chronic cholestasis for a variety of different reasons. So, for example, zinc is thought to be low because of potentially poor intake, malabsorption, and increased zinc excretion in the urine. And again, not fully understood why, but has been well described in infants with chronic cholestasis. Essential fatty acids are obviously important because they are long-chain triglycerides, and thus they are not adequately absorbed in cholestasis for the reasons mentioned above. And then even something like calcium and phosphorus have been shown to be reduced because of reduced intestinal absorption. This is because fats that are not absorbed can form insoluble complexes with calcium and phosphorus. So all of these things need to be considered, and there are other micronutrients that also need to be considered and monitored appropriately in these patients. So I hope this presentation was helpful and highlighted some of the principles of management of neonatal cholestasis. Thank you very much.